Welcome to the SAB's October educational webinar event, Pleural Effusions 2020 Literature Update on Critical Care, Imaging, Pathology, and Procedures. Before we get started, a few housekeeping items. You have all joined in the listen-only mode. Please ask questions throughout the webinar by using the question feature. We will address them during and after the lecture. Any we do not get to will be answered by email after the webinar. Dr. Kumbo is our SAB treasurer, and he will be our moderator today. Dr. Kumbo is a board-certified interventional pulmonologist, critical care medicine, and pulmonary medicine physician. Dr. Kumbo?
Hi there. I really want to appreciate the time that Jennifer has taken for the past 4 years. She's been working as a treasurer, as a VP, and she's bringing a different perspective to our Society for Advanced Bronchoscopy in a way that being an interventional pulmonologist, she is able to access different ways to conceptualize pleural disease. The background of, we don't have enough time to talk about everything that Jen accomplished in her past 15 years in practice. She practices in Hershey, Pennsylvania. She's an IP doc. Not only she's a director at Penn State Health, but also she is very active as a professor of medicine and surgery. We have seen her shine in many trials and research papers, and she is actively engaging in different societies. She will be our president for the Society for Advanced Bronchoscopy come this January the 1st. We give many thanks to both Michael Pritchett and Kyle Hogarth that have been helping us raise awareness of the many benefits of education through this type of virtual platforms. And again, we really appreciate Jen's time that she takes to tailor this presentation. And please, Jen.
Thank you, Gus. It's my pleasure to be here. And I hope in the upcoming years I can do as much as Kyle and Mike and you have done for the society. It's been an interesting year. I think everybody can agree. And when I thought about pleural disease, there's also been so many very important and applicable papers to what pulmonary critical care docs do that I had some trouble narrowing it down, but we'll see how things go today. I think these papers that I've chosen are fairly interesting and are easily applied to our practices. Okay. I have nothing to disclose with respect to this presentation. I do serve as a consultant and advisor for Olympus, specifically in the aspiration valve system division. So, as I said, the year in review for pleural effusions was pretty exciting. I chose 4 areas that are common to our everyday practice for pulmonary and critical care physicians. Most of us attend called to help with procedures on occasion in the ICU. We all use ultrasound on a regular basis. And probably one of the most common procedures performed both on the floor and in the unit are thoracic. We send the fluid for analysis. So a mention of pathology and cytology, I think, is warranted. So everybody is aware that pleural effusions represent a very large proportion of healthcare costs in the United States. So Drs. Light and Journal Review in 2018. They quoted an annual incidence of 1.5 million pleural effusions per year. So obviously this is a source of considerable morbidity for our patients, but also a huge healthcare cost concern. So today I have 4 objectives. I'm going to discuss significance of pleural effusions within the intensive care unit and some outcome outcome parameters of intervening on these and not intervening on these. I'm going to explore how well we do with ultrasound from a recent paper in Chest that tries to see if we are as good as we think we are at predicting whether we've got a transudate or an exudate. We're going to review the Gravitas study, which looked at looked at two methods of pleural drainage, suction versus gravity during thoracentesis. And finally, consider the significance of a diagnosis of all dread the suspicious for malignancy in fluid cytology. So a group from Tulane headed by Marjorie Bateman wrote this paper in the Journal of Intensive Care Medicine. And they studied the impact of pleural effusions and pleural fluid drainage on patient. This study raised several questions. The literature has been divided on what exactly the significance of an effusion is and what impact it has on our ICU patients. Some studies have quoted that more than 60% of critically ill patients have pleural effusions. So these studies have not used chest X-ray as a primary way of identifying them, rather more sensitive methods such as CT scan and ultrasound. So it also characterized the effusions radiographically without actually looking at the pleural fluid makeup. So most of these were considered to be transudates, secondary to volume overload, CHF, etc. The most common etiologies for effusions in the ICU, volume overload, obviously, pleural infection, malignancy, and organ failure such as end-stage renal disease. Dr. Madison did show at one point higher Apache scores, longer ICU stays, and longer mechanical ventilation time. However, there hasn't been a study that really looked at the clinical impact parameters and whether or not drainage was performed or not. So the question became, what is the clinical significance of effusions, their drainage, and what is the impact on outcomes? The largest meta-analysis to date failed to either support or refute that pleural effusions in the ICU had any effect on the parameters of mortality, length of stay, or need and duration of mechanical ventilation. The study design was a retrospective cohort analysis. The data source was the MIMIC-3 database. This is a freely available database to the medical research community. It contains the de-identified health data for over 40,000 patients that were treated in the ICUs at the BI Deaconess in Boston from approximately 11-year period. So patients with pleural effusions were matched to patients without pleural effusions by admission diagnosis, gender, and disease severity by a SOFA score. One thing to point out here is that the identification of the effusions was by chest X-ray. And as we mentioned before, chest X-ray can miss many effusions. The inclusion criteria included anyone over the age of 18 who had a diagnosis of a pleural effusion or in their records, pleural fluid analysis, obviously indicating that they had a drainage procedure done. The exclusion criteria were any mention of empyema or patients who were less than 18. searched by their ICD-9 codes. And as I mentioned before, any patients who had pleural fluid data were included as well, and they were procedure those patients had. So patients with effusions that were drained were matched to those who did not undergo drainage for the same parameters: admission, diagnosis, gender, and the SOFA score. By far the most common procedure was the thoracentesis. This was followed by chest tubes, and the minority were actually the surgical cases, so VATS, pleurodesis, etc. The other thing that was examined were transudates and exudates. So approximately 1,500 patients underwent fluid drainage. So approximately 40% of the patients with effusions. So transudates and exudates if there's an albumin available, the albumin gradient was used to reclassify some of the exudates as transudates if the patient had been diuresed. Patients with transudates were then matched to those with exudates for admission, diagnosis, gender, and SOFA score. So there were mostly exudates in this study. There were 953 patients with exudates versus 59 with transudates. And this is in counter distinction to what has been reported in some studies, although again, those studies didn't actually look at the composition of the pleural fluid. It was judged basically upon imaging and anechoic fluid being more likely to be a transudate, which we will visit that again later. The most common diagnoses were pneumonic effusions, which is about 43%, CHF and volume overload in 26%, malignancy in 14%, hepatic hydrothorax in 3%, pancreatitis in 2%, and this is percentage, and atelectasis in 2%, and hemothorax in 2%. And as you can see here, there was no significant difference in mortality, length of stay, need for the two groups with the transudate and exudate. The primary outcome that they studied was 1-year mortality after hospital discharge. And what was found was that patients that just by having a pleural effusion present on chest x-ray had a significantly higher 1-year mortality. These are the survival curves here. It's much less significant in the drainage versus no drainage group. They did a log rank survival analysis, and this did not show a significant difference in the survival curves, meaning that the presence of an effusion increased your mortality if it was drained or not. But patients who were drained had an increased mortality when compared to no procedure. The median survival for patients undergoing procedures was about 176 days compared to 210 days in the patients who did not undergo an intervention. So their conclusion was that presence of effusion is associated with worsened clinical outcomes in the ICU setting. The effusion patients also died more frequently in the hospital. They stayed longer in the ICU, and they needed mechanical ventilation for a longer period of time. So now what do we do? Tap or not to tap? So if by this study, patients who had pleural effusions are associated with worse outcomes, or are we to manage these? So does that mean we don't intervene on these effusions? Why is the difference? So We're reviewing here the drainage group versus the patients who did not. And what we noticed overall is indication. Why did these people have a TAP? What was the reason? Was it for diagnosis? Was it to change management as far as, you know, helping with ventilator and respiratory mechanics, etc.? So what did we learn? If we take it at face value, the presence of pleural effusion is associated with increased mortality in the critically ill, regardless of disease severity. It's possible and makes sense, this is not surprising, that pleural effusions are a marker of severe disease and worsening organ dysfunction. It did also, the study refuted that most ICU effusions are transudates, at least in this cohort, with the use of pleural fluid analysis. So this is the first study that actually tapped the patients and analyzed the fluid instead of going off of ultrasound. We also noted that the drainage of the effusions was associated with increased mortality, length of ICU and hospital stay, and duration of mechanical ventilation. Now, does this mean we should alter our practice? Well, I would argue we still need a lot more information. So this study was from one center for over 12 years. There could be regional differences. The incidence of ICU effusions in this study is compatible with other studies that use chest X-ray. However, we mentioned that the range of incidence of pleural effusions was from about 7% to over 60%. There was no data on the indication, which I think is a big piece of information that would yield a lot more light on this study. So why do we tap these effusions in the critically ill? To either change or confirm diagnoses. And when you drain, you change your diagnosis. People get tapped to improve their respiratory mechanics, get them off the ventilator, make it easier to extubate. Patients with fevers and symptoms concerning for infection probably were more likely to obtain drainage. So there's a slight. So overall, we need a randomized controlled trial addressing these variables, but this was a valuable study and the first of its kind to look at these parameters. There was no data on the indication we mentioned, nor volumes present or drained. So maybe the sicker patients had more of an effusion. And also, I think one needs to look at the different procedures themselves, and that may have had an impact on outcome. So, for example, think of your cirrhotic patients. We all know that they do much worse when you put chest tubes in them as opposed to intermittent thoracentesis. So the second paper, we're going to move on to imaging. This is Dr. Shkolnik and colleagues looking at whether pleural fluid diagnoses, more specifically transudate versus exudate, can be differentiated by using just ultrasound. And this kind of feeds back on the prior study in that some of the referring studies looked at the ICU incidence with ultrasound, and some of the characteristics of ultrasound, they were automatically characterized as transudates. So we all do ultrasounds on a daily basis. It would be really nice if we could bring our chest tube kit, bring our thoracentesis kit, go to the bedside, put the probe on the patient and say, oh, I just need my thoracentesis kit today. Or no, I should probably have a chest tube. So the clinical question that asked was, what is the diagnostic accuracy accuracy, thoracic distinguishing. So we are more likely to put a chest tube in for an exudate or versus just a simple thoracentesis. So they examined 300 effusions in 285 patients. They found 76% were exudates by pleural fluid analysis. But when they looked at the characteristics on ultrasound, they had anechoic effusions in 40% and complex effusions in 60%. So obviously there's some crossover. I'll show you the data. These 4 categories were used as a standard interpretation after calibration of the machine by 4 investigators. There were 4 docs that did the ultrasounds. The decision to perform a thoracentesis was made by that treating clinician on the basis of the available clinical data. The ultrasound only really altered that decision if the fluid was basically, there was too little to drain. So we have A, which is kind of a classic picture of an anechoic, simple, quote unquote, pleural effusion. B, material in an anechoic space. So there's no septations there. You have very simple looking fluid on the top and then some echogenicity kind of back in that recess. C, the septations there are obvious. And then D was classified as complex homogeneous, meaning there were also some anechoic fluid and then dispersing of this echogenic debris throughout the space. So how did they do? Data here shows that the patients, well, the demographics, which I didn't include, they were fairly 4 years, 53 men to 47 women. What is interesting though is the BMI ranged from 14 to 70. So we'll talk about that in a bit. So there were 40% were simple effusions on ultrasound versus 60% were complex. And these were further divided. So then the actual diagnosis is listed below. So the transudates, there were only about 24%, and the etiology of the exudates, mostly infectious, followed by malignant, and then category of other. So what was the correlation? 50%, 56% of anechoic exudates, anechoic transudates, 44%. And most of the complex effusions were exudates. So there's a good number of exudates which appeared anechoic, not as many transudates that appeared complex. So when the statistics were done, really what we found is that an anechoic appearance to an effusion had a low predictive value for being a transudate. A complex effusion had a high predictive value for the detection of an exudate, but neither were sensitive or specific. So therefore, an anechoic effusion on ultrasound, you can't really say, oh, this is definitely a transudate. The further subdivisions also did not have any significant diagnostic value. Now, this doesn't mean that when we look at an ultrasound and you have somebody with pleural nodularity and thickening, that, that is not a malignant effusion. But there was no, and they did not actually do the sub-analysis of the specific findings to predict specific diagnoses in this study. Okay, so what did we learn? Overall, this is one of those negative studies that still gives us a really good, bit of information. And what we learned overall is that we're not that good at predicting transudates and exudates just by ultrasound. So an anechoic pleural effusion can be transudative or exudative, and it does not therefore obviate the need for sampling. However, findings of a complex effusion, you have a high likelihood that that's going to be an exudate. There were a few limitations. The image interpretation by the investigators was blinded, but some were the treating clinicians. They may have had a recall bias for the specific patients. The ultrasound images, as we all know, can be very hard to standardize. They did a very thorough standardization using the gain and imaging the gallbladder to try to set the parameters for each patient. However, it's very operator dependent. And also, this is where I would have liked to have seen a sub-analysis on the individual patient characteristics, because doing a tap on somebody with a BMI of 14 is a lot different than doing one on somebody with a BMI of 70. So now that we've done our ultrasound, we're going to discuss the cytology from the pleural fluid, and finally we'll end with the gravitas study. So this is Johns Hopkins Pathology Department, published in the American Journal of Clinical Pathology. And which one of us has not gotten that dreaded diagnosis of suspicious for malignancy and sat there and said, what actually does this mean? And what should my next steps be? So the sensitivity of fluid is about 60%. You can increase that by a few percentage points with subsequent taps. Adenocarcinomas are the most common malignancy that we diagnose. And this is followed by leukemia and lymphoma. So the definitive diagnosis of malignancy is not always that clear, is what our pathologists are telling us. They took 6,178 pleural effusions that were processed from 2008 to 2018 and looked for the diagnosis of SFM, or suspicious for malignancy. So this is a retrospective analysis. So of those 6,100 pleural effusions, 90 patients were identified as having a diagnosis of suspicious for malignancy. We can understand somewhat the hesitancy to call a malignant pleural effusion as it portends stage 4 disease and a much worse prognosis. It's difficult for pathologists at times to commit to a definitive malignant effusion when you have adenocarcinomas with intracytoplasmic mucin and mesothelial cells that are really revved up and have cytoplasmic vacuoles and are degenerating or reactive. Was 86% who were diagnosed with clear malignant effusions. And these were matched male to female, mean age of 61 years. 87% of the suspicious for malignancy had a quote history of malignancy, and that was the only term that was provided, not active, past, etc. Non-malignant, so these were previous taps. 1 had suspicious for malignancy, and 8 had prior diagnosis of malignant effusion on a prior tap. The other thing that was looked at was volumes of the effusions were also compared. It's intuitive to us that the more the better, and your false negative rates. The more you have, the more you can spin down. They did process these all in the same manner. And then they compared the characteristics of the with respect to volume, and also whether the addition of immunohistochemistry made a difference. So the average sample that was submitted was about 400 cc's, and it ranged from 5 cc's to the 2 liters that I spoke about. The malignant controls are here in yellow. Diagnoses were made of suspicious for malignancy compared to the proven malignant effusions. So, question, was this dilutional? This is, the more volume, the higher the rate of that diagnosis of suspicious for malignancy. The thought was then, atypical cells were present, and they were defined as highly atypical with morphologic features that were suggestive of malignancy, but they didn't have high numbers. And I mentioned the reactive mesothelial cells that have atypical appearances that could be interpreted as malignancy. So the next step, let's do some immunohistochemistry. Let's see what shows up. So 12 cases, immunohistochemistry identified a second cell population. However, this wasn't felt to be helpful in clinching that diagnosis because there weren't enough to call it definitively. The results were suspicious for, and this goes with our previous statement that adenocarcinomas are the most common, followed by lymphoma and leukemia. And then they also had some suspicious for sarcoma, a melanoma, germ cell, and a not otherwise. Seeing cells in the background, the cytopathologists, and this was, these cases were reviewed by 2 boarded cytopathologists independently. Seeing 1 or 2 cells in the background was felt not enough to make the diagnosis. It was a very gray area because they didn't give a number of cells, like a threshold to cross, and a lot of it. So somebody with a history of widely disseminated aggressive disease was more likely to get a diagnosis of malignant pleural effusion with fewer cells, but they did not use a threshold. So why do we care about this? Well, these diagnoses they're not benign. They're suspicious for malignancy, does not mean negative. So they followed out the survival of the suspicious for malignancy patients when compared to the controls with malignant pleural effusion. The survival curves were not statistically different. So the patients that are labeled with these suspicious for malignancy have bad disease. In fact, if you look at suspicious for malignancy was 117 days when compared to the actual malignant effusions. In the 90 patients in the study, the clinical follow-up went out up to even 5 years. 9 out of the 90 eventually. There was only 1 patient who had multiple workups and that failed to prove any malignancy after a 5-year period of time. So this brings up some questions on possible, different mechanisms for the fact that the larger volumes had a low cellularity. Okay, so maybe dilutional. Does that point to a different mechanism for effusion development? So perhaps increased vascular permeability. Because traditionally we think malignant effusions is more of an imbalance of absorption, tumor blocking the lymphatics and preventing the reabsorption of pleural fluid. However, there have been some studies that have looked at the formation of pleural effusions in malignancy, and there are many molecules and that are responsible for pleural inflammation, angiogenesis, and basically increased vascular permeability. So you have leaky vasculature that contributes to, I guess you could say, production, or rather than decreased reabsorption. It's been shown that tumors with driver mutations are more likely to develop malignant effusions. So where do we go from there? Studies of how to improve cellularity and yield in samples with low cellularity are needed to help eradicate this SFM category. So what did we learn? Mainly, that the risk of malignancy in a diagnosis of suspicious for remains high, as the survival curves are the same as those for malignant effusions. And the statistics on having a malignant effusion are pretty dismal as far as survival goes, with an average of 3 to 4 months. So if workup, it's probably in the patient's best interest to pursue something more definitive if there is no history of malignancy, or so further biopsies and clinical behavior should warrant how that's approached. So, question, would you put a tunneled pleural catheter in an effusion that was suspicious for malignancy but kept coming back and was symptomatic? I think you could argue yes. So the last paper that I looked at was the Gravitas study, and this was the interventional pulmonary disease outcomes group led by Dr. Lentz. So thoracentesis is a daily practice for many of us who work inpatient and also in the clinic. So there's been much debate on what the most effective way to accomplish pleural drainage that is the safest and most comfortable to our patients. Overall, thoracentesis is a low-risk procedure, but complication rates of more than 5% have been reported. These appear to be more common with larger volumes of fluid that are aspirated, and perhaps with vacuum suction. So despite these associations, there have been many studies using pleural manometry during thoracentesis, and even these have failed to show improvement in patient comfort or reduction in serious complications. Mitigate these negative pressure complications that we think about would be the use of gravity. The study hypothesized that gravity drainage would result in less chest discomfort compared with suction drainage. The study was not powered for the other elements that were mentioned here, so chest discomfort was the primary variable that was looked into. The study design, this was a prospective multi-center, single-blinded, randomized controlled trial. The randomization was done by the computer. Envelopes were not opened until the thoracentesis catheter was actually in the pleural space, and the patients did not know which one which arm that they were enrolled in. The effusions had to be about 500 cc's or more. They were randomized 1-to-1 to active aspiration or gravity drainage. There's a little bit of a discrepancy there, and I'll explain that. The patients then rated their chest discomfort on a visual analog scale, and these are the ones that have been well validated, with 0 being no pain at all and 100 being the worst pain ever. And they gave answers prior to, during, and after the procedure. Thoracentesis were stopped for complete evacuation, intractable cough, or chest pain. And the primary outcome was chest discomfort, scored 5 minutes following the procedure, and also looked at where the secondary outcome was dyspnea. So discomfort and dyspnea 48 hours post-procedure. So this is the trial profile. 201 patients, 142 randomized after elimination for various reasons. The suction arm is manual aspiration with a 60 cc syringe. The slight imbalance to allocation here was because you had 10 sites enrolling simultaneously from these block randomization schedules. So things were corrected for that. The volume drained was not significantly different. There was also a post hoc analysis for off protocol, excluded 11 procedures that were done with continuous wall suction. So as far as their primary outcome was concerned, there was no significant difference in pre, during, or post-procedure chest discomfort up to 48 hours. The scale that was used was, again, the 0 to 100. And it was also used for the breathlessness, which was their secondary outcome as well. So the same amount of fluid was drained, the same reasons for discontinuation. Is very intuitive, is that gravity longer. It was about additional 7 to 8 minutes for the gravity arm. They had a very low complication rate, as you can see down at the bottom. There were no instances of ex vacuo pneumothorax, re-expansion pulmonary edema, bleeding, or there was one tiny pneumothorax that they attributed to air being in the line, and it was only about 2 millimeters on the chest x-ray. The dyspnea scores, they continued to improve in both groups over the 48 hours. Again, no difference toward better, which is usually the case after a thoracentesis. All right, so what did we learn? There's many variations that exist in drainage techniques. Other ways to drain, included intermittent suction, like what was tested here and what I think a lot of people use in practice, continuous suction via vacuum bottle, wall-based suction, drain, all of these are negative pressure. And they have varying magnitudes that have been studied ex vivo. Dr. Alrayes also studied these. So an evacuation bottle, for example, is about negative 963 centimeters of water pressure. The Luer lock method, about 802, and wall suction turned up to maximal containment. Dr. Alrayes used digital manometers positioned in line and found maximal negative pressures of minus 250 of water. So this is the actual patient testing, and minus 115 with an evacuated bottle. So that's the, I guess you could call the in vivo model. Gravity drainage at 100 centimeters below was only minus 17. So, there are huge variations in the negative pressure that's used to evacuate pleural fluid. And major complications of thoracentesis, pain, re-expansion pulmonary edema, ex vacuo have been associated with these increasingly negative pleural pressures. So this study looked at whether changing the degree of negative pressure from, let's say, minus 250 centimeters of water to minus 17, whether that improved discomfort. And no significant patient chest discomfort between active aspiration and gravity drainage in free-flowing effusions. So the only difference was gravity takes longer. They also acknowledged that predicting unexpandable lung is difficult. How do we know, that patient is going to have a trapped lung? And manometry has been relatively unhelpful in that respect. So questions answered or raised. And gravity are equivalent. They both appear safe. Gravity drainage takes longer, not surprising. The limitations of this study, again, this was not powered for detection of the quote more expansion pulmonary edema or pneumothorax ex vacuo. And there was no use of manometry used in this study. Some other criticisms that were offered were consideration of, what degree of atelectasis was present prior to the thoracentesis as a risk factor. How much, is the volume taken more important than, the actual pressures, and these still have to be looked into. So I'd like to conclude the talk with, I like to make things simple. So what I've learned from the ICU is that patients with effusions have worse outcomes, and this may seem very intuitive. But, are you going to take the non-drainage because of the drainage process? And I'm not so sure that that is the case. So I'm going to consider the indication for drainage. Why am I going to drain this effusion? How am I going to do it? Is it because I'm going to change the diagnosis, improve mechanics, etc.? Again, think about, the hepatic hydrothorax with a chest tube. We know that's not a good idea. I also learned that appearance of effusions on ultrasound is not sensitive or specific to call a transudate versus an exudate. That sampling is still needed, but a complex effusion is more likely to be an exudate. And I think that's a fair take-home message. As far as our pathology colleagues, history is important to provide the pathologists an analysis of pleural fluid. They consider less cells needed for diagnosis in somebody with a severe disseminated disease. Suspicious for malignancy effusions should definitely prompt further workup to prove malignancy, as these survival curves for a malignant pleural effusion and the diagnosis of SFM are the same. So this is not a benign or negative diagnosis. And finally, from gravitas, gravity and manual suction drainage are equally safe. Gravity drainage takes longer. I think, we are still have a lot of road to go on this, because we cannot predict, even with manometry, who is going to develop complications. So, there is more than one way of doing things, and, tailor your practice to what's available, and listen to your patients as far as their chest discomfort. I'd like to thank Society for Advanced Bronchoscopy for asking me to present. It has been my pleasure. And greetings to you all from Hershey, Pennsylvania.
Thank you very much, Jen. Excellent presentation. I have a few questions, and some of them are directly related to your educational points, and some of them are a little tangential that get a little more into the realm of interventional pulmonology. So one of the questions from our panel is about continuous drainage versus intermittent thoracentesis in non-cirrhotic situations in order to try to better control. I don't think that the question was precisely about tunnel pleural catheters, and I'm assuming that you may have two different answers for malignant and non-malignant. So maybe some take-home messages for like back pocket pieces of information for audience, Jen?
As far as, are we talking about malignant effusions or thoracentesis?
It's a the question more in non-cirrhotic. In non-cirrhotic, obviously the management of malignant pleural effusion with pleurodesis, trying to achieve pleurodesis with talc or TPC has to do with mortality. But let's talk about more the undiagnosed pleural effusion that comes to you and keeps on reaccumulating, and you see the patient after two thoracentesis.
Yes. So, I mean, it depends on your skill set and colleagues, because medical pleuroscopy in a recurrent exudate would definitely be would be indicated with a space there in pleural biopsy. Some centers do that. Their pulmonologists, interventional pulmonologists do that. Others, would refer to VATS. And it would also, in my experience, depend on the etiology of the malignant effusion, or if we got a diagnosis as to whether pleurodesis with talc would be appropriate at the time. A recurrent symptomatic exudate warrants some other intervention, and if that, depending on the clinical state of the patient, could just every day, every other day. So it varies, but I think if I had a patient with a recurrent exudate, I would do probably a medical pleuroscopy with pleural biopsy and
obviously we all encounter situations that we have different etiologies for pleural effusions, and almost a knee-jerk reflex for everybody is to do an initial thoracentesis. We agree that whether it's undiagnosed effusion, we always go get fluid for, obviously staging for stage 4 if it's malignant, or trying to figure out transfers and exudate. So my back pocket piece of information for this is when I have an exudative lymphocytic predominant with no neoplastic cells, that should light up in the dashboard to act on it and not necessarily sit and watch. Now, what would you do in a situation that you have a lymphocytic predominant exudate, you have a lung mass, you have maybe an N1? Would you be aggressive to try to do an MT to try to get pleural biopsies, knowing the excellent diagnostic yield? Some centers, really go back to navigation and EBUS. What would your suggestion be for the audience?
I think thoracentesis to start with is definitely the right thing. You get a lymphocytic exudate that, as you mentioned, does raise red flags, because even lymphocytic transudates, end up being malignant effusions. I think I would go on and stage the mediastinum with EBUS, get a biopsy of the primary, and then after that, I think if pleural biopsy were feasible, I would go for pleural biopsy after that.
Right, and I think that brings an excellent point of trying to get a diagnosis. I would say that in the very unfortunate situation of maybe a small cell with a pleural effusion, if we don't diagnose malignancy on the pleural fluid, whenever you biopsy and it's a small cell and it's already nodes, I don't think it's going to change much of the treatment, even though you would like to appropriately stage, obviously, but we know the prognosis for delaying prognosis for delaying a diagnosis is bad in small cell or any malignancy. Now, I have two more questions, and obviously we really appreciate the time that you took, Jen. One of them is, what would your suggestion be for stepping stones in order to develop some sort of pleural service that will be well versed in the art of pleural effusion. As you know, most of the hospitals don't have interventional pulmonology. And what would you say that it would be some back pocket pieces of information for our pulmonologists to set up something? How would you set it up logistically initially, not the whole thing?
So obviously, you want to have your own equipment. You can't rely on, borrowing the MICU's ultrasound or the SICU's ultrasound. I think that's inherent in having a pleural service. That way your imaging is standardized. You have at least one attending physician. If you have residents, that's fantastic, and fellows, but also perhaps an advanced practice clinician. And they can be very useful in, forming a pleural consult service, assessing patients, and then, presenting them to the pleural attending, and then evaluating for whatever intervention might be appropriate. So we have a pleural clinic that also we've enacted, where even patients that we've seen as inpatients follow up in for effusions that are diagnosed, and to see whether they're recurring, to give results, to plan further interventions. That's kind of a step beyond, but if you want a pleural service, the bare minimum, I think, your own equipment, somebody who is, well-versed in ultrasound, and another, person, whether it's a fellow or advanced practice clinician, to field all the consults and help with arranging.
Excellent. Two last questions, and they can be brief answers because obviously, unfortunately, we're running out of time. And again, we really appreciate you sharing experience with us. The two questions are, one, we all know that the more fluid that we send, the better. Sometimes we get 3 liters out, and sometimes we want to send 1 bottle, but obviously you touched on this. The more fluid that you provide the lab, the more likely to make a diagnosis. So that would be obviously one closing comment about that. And the second is, what is your go-to for a small pneumo post-thoracentesis in a patient that is asymptomatic? Would you consider following with x-rays? Would you consider a therapeutic aspiration? What has been your practice whenever you have an asymptomatic small pneumo that, the patient is doing okay?
We follow them. We don't, we'll get an x-ray, make sure that it's not increasing over the next, say, 6 to 12 hours. Even if it's stable the day after, we still feel confident in discharging the patients with the understanding happen, they need to return immediately. Comment on the volume of fluid. Our pathologists actually ask us to send everything that we get. They centrifuge it down for a cell pellet and block, and paraffin embed them. So we do send whatever we get.
Excellent. Well, there are more questions, but unfortunately, we run out of time. Jen, we really appreciate the time. We wish you the best of luck leading the Society for Advanced Bronchoscopy. We look forward to an upcoming election for a treasurer. We will be very soon contacting all our members. We really want to appreciate our industry support.
Yes.
And definitely, Jen, we are very delighted to have you presenting this, and we wish you the best of luck.
Well, I hope it was helpful, and it was my privilege, and I hope that I do as good a job as my predecessors, and you as well, Gus. So thank you.
Thank you, guys. We're going to wrap up. Emily, anything else to add? Otherwise, we will adjourn.
All set. Thank you, everybody, for joining. Good night.
Thank you.